threshold for pain. And evidently everybody seems to fire at the same, intensity. But you don't necessarily have the same tolerance. So tolerance isn't the same thing as threshold. Threshold, it opens gates, sodium comes in, what goes out. Sodium comes in, potassium goes out, so everybody kind of does it at the same time. But tolerance, what can lower your tolerance? Not having enough sleep, being real sick is going to usually lower your tolerance for pain. And some people have a higher tolerance. Usually, older people in general seem to have a higher tolerance for pain. They'll be walking around, they'll have this really gross thing on their foot, and they just kind of put up with it. Okay, not necessarily all the time, but think about tolerance is different for everyone. The rest of that one paragraph on the top, where I'm reading through the top, there's something to do with if you take, and you're going to have to amputate, say you have to amputate a hand. The idea was you want to knock the person out, which knocks them out centrally, and then you cut things off and you tie stuff off. But when people would come to, they could still feel their fingers. Now again, it wasn't the real fingers, you're just stimulating the nerves, and they think that the pathways somehow have been reinforced for pain. So the idea, and it's an idea, I don't know if they do it, but the idea is that you actually, if you let a nerve pathway go and go and go, you actually learn it more. You get used to it. So it's just like my pathway from my leave here to get to my house is so set after 24 years that if I get off and I got to go to the grocery store because I don't have any milk, I'm going to end up at my house. There's no way I can go anyplace unless I'm doing it every second to keep doing it. So you can develop this learning pattern for pain as well. And they're saying, and that has to do with these NMDA, which you don't have to know, but it's the name of this receptor that has to do with learning pain. So one of the ideas is if you put somebody under to do something like a major surgery or cut off a limb, then you also should block it locally. Because if you block it locally, then you're not firing it locally. Because you could be firing a pathway and not be aware of it, right? It's kind of like when the dentist, you go in there and they numb you. They numb you for pain, but can you still feel their hands in there? So you have other senses, but you don't necessarily. They're just mostly doing it for the pain. So this one talks about you do an epidural, and how does an epidural work? See, we'll talk about the three membranes. What's the three membranes? The meninges. Okay, here's your spinal cord. What's the outermost meninge?
Dura.
Okay, so this would be the dura. Dura, you're durable, and then here's the bone. Okay, here's the bone out here. So what is the space above?
In between there.
Okay. Down here is the spinal cord. I'm so bad at drawing. Okay, so here's the spinal cord down here. So what is this? Here's the dura. It's on top of, so usually you say epi and then dura. Okay, your epidural space. And that space has, and here's the bone, and so this space has fat and everything. Well, these nerves that come off, the nerves that are going to be coming off, remember you have a root, a dorsal root and a ventral root. Which one's the dorsal? Top. And what does the dorsal root carry? Okay, it's called afferent. It means sensory root is the dorsal root, right? And this one down here? Okay, this is called efferent going out, and it's the ventral root. And this is only, this efferent, the ventral root is only motor, right? Okay, so this is only motor, this is only sensory. So again, if I cut the sensory root, I'm still going to be able to do motor. If I cut the ventral root, I will still feel things, but I won't be able to move, right? Mm-hmm. So you need to know, if I go and cut things, I cut this, what happens? Lose sensory. If I cut the ventral root, I lose motor. What happens when it comes down together? These two are coming together. This would be spinal nerve. And some of them are going this way, some of them are going this way. If you cut that, you're going to lose motor and sensory at the same time. Okay, so you got that part down. If I give an epidural, if I go into the epidural space, you hopefully do not go through the dura, because you don't want to numb the spinal cord, but you're trying to come over here and numb the roots and out the spinal nerve. So when you give an epidural, you're trying to do it as it comes out, so it's like a local block.
So where do you put the needle?
So you're going to put the needle in the epidural space if you want it to be localized. So which is why it's called an epidural, right? You know, and if you know more about your spinal cord and that, you probably would never let them get near you with an epidural. But anyway, but I'm the only
Wait, what did you say?
if you knew. I know, because most.
I already had mine. I'm good.
I know you're already done.
I'm okay. Go ahead and say it.
Okay, so this is the dura, right? That's the outer meninge. How about what's the next layer down? Arachnoid. Okay, that's the arachnoid. What is below the arachnoid? Okay, the pia is the one that's right on top of the spinal cord. Okay, what is the space here, though? This is a real important space. Below, it's the subarachnoid space. Okay, what about the subarachnoid space that's so important? What is in there? Cerebral spinal fluid. So what happens if they come in and they would put a needle in here and they would get down into the subarachnoid space? Then if you do something to deaden that area, trying to deaden out here, but the needle's comes down too far, then the subarachnoid space is connected to subarachnoid space around your brain. And so it can make you stop breathing. So if they do those epidurals, they're watching you all the time. Because if you have any trouble breathing, they think you may have got it into here, and then it travels up to the brain. Because this space here, the subarachnoid space, this space around here, is connected to the subarachnoid space around the brain and the spinal column, around the brain and around the brain stem and all that.
So why does it, like, when, like, if you're laying on your side, then it works more
on the dependent side?
Yeah,
my guess is, and again, I don't know all the etiology and stuff, but it's the epidural space has fat in it. And there's connective tissue. So if you inject it in here, I'm thinking if you're laying on the side, gravity's just going to make this side number. Yeah. It's more for a numbing at a local level. They used to call
They did say it's because of the gravity or whatever, because they wanted me to lay on my side because they couldn't find one of the babies on the monitor. But when I laid on my side, I can feel everything on this side.
So the anesthesia wasn't working as good on that side, right. The epidural.
Yeah, and they said it was because of...
I couldn't even turn.
Well, they had to turn me. I couldn't move myself.
See, when you do the epidural, it's not affecting the uterus contracting because that's a smooth muscle, okay? So it's not because the smooth muscle is contracting, but what it will do is it deadens the abdominal muscle, so when they say push, someone has to tell you to push because you can't feel it when it's time to push. Yeah, but the epidural does block a lot of the pain. It's blocking the pain, that's why you're doing it. But if someone comes in and does an epidural and it goes into the subarachnoid space, and then they bring the needle back out to here, put the anesthesia in there, sometimes you'll have a hole in that dura. If there's a hole in the dura, then you will start leaking cerebral spinal fluid out, and if you leak cerebral spinal fluid out, it gives you what you call a spinal headache. Horrible headache, medicine doesn't touch it. So, you know, you don't let someone touch you that doesn't know what they're doing and it hasn't done it many times. And we call those interns or residents.
Yes.
Huh?
Mine had cerclage put in during my last pregnancy, and they did a training person, and my back hurts so bad.
And it will give you, if you pull the cerebral spinal fluid around your spinal column, around your brain, is a certain pressure, and if it's starting to leak out, the pressure decreases and it will give you a headache, a really, really, really bad headache.
Yes.
Huh? And so, and I had someone do, once an intern do, I was for something else, but they were doing a spinal tap, and don't let anybody touch you that doesn't, you ask them how many times have you done this, and they used to call them interns, now they call them first-year residents. Those are dumb people.
True story.
They got to practice on you. Practice on somebody else. Yeah. And so where would you go in if you needed to get into the subarachnoid space? Because you want to look at cerebral spinal fluid. Where do you do it? Up here? Here? Down L4, L5, Y? Cord has ended at L1, right? And so as you go in there, then you're not going to hit any spinal nerves because they'll float out of the brain. So look, going into the subarachnoid space to take out cerebral spinal fluid is one reason, but if you're going to go into dead and you want to stay in the epidural space, you want to know the difference in the spaces.
So does it give you a headache if they have to get this fluid?
Well, what they usually, see, I think what happens here is if you go through the dura and you pull the needle back out, they might not know they punctured it. Okay, and then as you start to leak fluid, the pressure goes down and gives you a headache. So if they're going to go into here, I think what they do is they inject some blood in here, and the blood has clotting, and it clots it, and it will close off the open. So then that would be okay. But it's only when they don't really know that they went through and came back. And I think they can feel it. Someone that knows what they're doing, I think they can feel it like popping in and out, but someone that hasn't done it very much.
So once they've done it, can they go in and do the blood thing? Like once it's already happened?
Yeah, then they would go in and try to put blood, because blood can clot, and it will help close the hole off, yeah.
Or they could stab you in a totally different place and cause it to make it worse.
Okay, so this is the dirt.
Thanks. Yeah. You were so optimistic.
How many have you done?
You're fired.
And you just start screaming.
I just decided that you were fired.
I'm not a good patient. Give me somebody else. Okay. So this is the epidural space, has fat. This would be the dura. And this would be arachnoid. And usually the arachnoid, they call this the subdural space, but most of the time these two are really right next to each other. So the only time you would worry about a subdural space is if you're bleeding into that space and all of a sudden it opens up, right? So do you want to bleed? You don't want to bleed subdural space. You don't want to bleed into subarachnoid space either. Because if this is spinal cord, you have an epidural space. If you're doing the meninges, let's finish up. What's the meninge that's right on top of it again? That's the pia, right? The delicate one, pia just sounds, pia. Sounds delicate. So pia means delicate mother. Dura means durable mother. Arachnoid means spider-like, spider-web looking. Okay, and so in the brain, here's your bone, and this is the dura. So there is no epidural space in the brain because the dura is right up against the bone and actually forms the periosteum of the bone. So that's the difference between the brain, meninges, and the spinal cord. Spinal cord has this extra space. And so what does the cerebral spinal fluid do? It's a cushion. Cushions around your brain, so you bounce it, and it's kind of hitting a water bath. Helps around the spinal cord, and does probably provide nutrients as well. Where do you make the cerebral spinal fluid? That's where it flows. That's the middle one, but where do you make it? You make it in the choroid plexus. And what is the choroid plexus?
Always forget that name.
A choroid plexus is a plexus of capillaries. It's like a ball of capillaries. Why would the blood, the plasma from the blood, the clear stuff, why would it leave a capillary and go into a space? Pressure. Lower in the space. Why would it go from the space back into a vein? Pressure. Lower pressure again. And so the reason it does it, it leaves the capillaries higher pressure into the ventricle, flows through the lateral ventricles to the third ventricle, and what's the skinny little tube? Aqueduct. Cerebral aqueduct. You need to know that for lab, I'm sure. And where do you have it most of the time? If it's occluded or there's a problem, it's cerebral aqueduct because it's so small. And then it goes into what ventricle? Fourth is under the cerebellum, and then it comes up around in the subarachnoid space around the brain. And so again, if you don't have enough, you could get headaches. If something is wrong and you can't reabsorb it, it can give you headaches. Or if you can't travel through there, it's going to press on the brain and cause all kinds of havoc. Okay, so know the three layers. Dura, arachnoid, pia. Where is the cerebral spinal fluid? Subarachnoid space. Where do you stick a needle for an epidural in the epidural space? Okay, and so I know the pictures are awful, but we've already covered it. So you need to make sure you can do the thing. Now, and this talks about the epidural is going to block the transmission. You don't want things to go up. Referred pain. Let's look at the referred pain real quickly. That's still the same handout. Now, during development, your heart is down here, but during development, your heart and your arm are close together in the tiny little embryo. And then the heart falls down here, and the arm grows out this way, but when they come back into close to the spinal cord, they synapse on the same neuron. Do you normally hear from your heart? No. Doesn't tell you, huh? Unless you have really major problems. So what do you usually hear from? Your arm, right? Because that's somatic. So most of the time, so if you look at this little picture, I tried to draw it. You have it in your book, and it has different colors. But on this one picture, if you look at on the right side, if you have pain right here, it's pretty easy. It's probably the heart. But if you have pain down here, this area here is going to be referred back to the brain, and the brain's going to think it's your arm when really it's your heart. Also, if you look at here, up here, some people will just complain, my jaw hurts. Could be pain from the heart. And why would the pain have a heart? You're having a heart attack. You're having lack of oxygen to the heart, and this is hurting. But you're not usually hearing the heart talk, so your brain assumes it's coming from a surface area. So the idea of a referred pain is a surface area where you're referring it or thinking the pain is coming from when it's not really coming. Because coming from the arm, coming from the heart, they're going to synapse on the same neuron, go up to the brain. The brain's going to think it's what it normally hears from, which is the skin, you know, or up here. So any of these places that have to do with the heart, that's how a person with having a heart attack. A lot of times they say it feels like you have an elephant sitting on your chest. Women sometimes feel like they're very, very nauseated and they think it's gastrointestinal. Women have a different sense sometimes. They don't have the classical symptoms. And if a woman has a heart attack, a major heart attack, she has a 50% chance of dying. If a man has it, he has about a 33% chance of dying, because you can recognize the symptoms better. And people don't think about women having the heart attacks. So it can be more fatal, and that's next semester. But anyway, looking at the gallbladder, sometimes your top of your shoulder hurts. And what it is the diaphragm is like this. The diaphragm is your breathing muscle, right? Okay. The diaphragm is what, it's kind of an arched muscle, comes off of what? The nerve comes off of C3, C4, C5. That nerve is called the phrenic. Remember the phrenic nerve? That's your breathing. It goes down to the diaphragm. The coming off the spinal cord, C3, C4, and C5. Well, if you have gas in your abdominal cavity, or they pump gas in so they can look at you. Like they want to look at your abdomen, they want to do, like a endoscopic. When they put tubes in and just look, they'll pump you up with carbon dioxide, and the carbon dioxide will push on here, and it will hurt up here. Now the diaphragm's down here, but it hurts up here, and it's because it's referred to a different place. You're not used to having the diaphragm hurt, but when it does hurt, they do the diaphragm here somewhere, it feels like it's up here. The lungs and the diaphragm feel like it's up here, and it's not. It's down lower, but the body thinks it's coming from there. That's called referred pain. It's referring to someplace else. Most of the thing, like this kind of pain, this kind of stuff, is called somatic. Things inside, like your heart, is called visceral, right? And so you normally hear from your somatic system. Most of the time we don't hear that much from your visceral system. Okay, anybody have questions on that? Because I didn't cover this. I didn't talk about it. It was there. Okay, so you know the parts. You know the dorsal root, the ventral root, the spinal. I like to ask questions. Chop this, what do you lose? Chop this, what do you lose? Chop this. That's an easy way to do it. Then the spinal nerve is going to branch into a rami, right? And you have a dorsal rami, which is small because it goes to where? The little muscles up and down your spinal column, right? And then the ventral rami is going to be a big one, and the ventral rami is going to do all the ones in the front. And if it's a group coming off of your cervical region, it's going to come off as like you got C1, C2, C3, C4, C5. And these nerves come off and they form a plexus. They're coming from the ventral rami and they form a plexus. And a plexus is going to go to one specific part. And the plexus, that's a cervical plexus. And I did that one. I did explain that one in more detail. I didn't do the brachial plexus and the lumbosacral. Just gave you this one to get started. The cervical plexus goes to the diaphragm. What's the name of the nerve? What do you feel like if you can't breathe? You really get frantic, right? You know, so this is called your frantic nerve, your phrenic nerve. Something to hook it together. That's the nerve that goes to the diaphragm, and the diaphragm is your major breathing muscle. So we go back because I want you to think about the layers of the spinal cord. If I have damage right here, if you damage the spinal cord, everything from here down is not going to work. So if I damage it at C2, can I breathe on my own? You would have to be on a respirator at all times. Okay. What happens if you damage it down here, like between C5 and C6?
You can't move.
Okay, if I damage it, we'll make it like C5. Okay, if it's down here, C5, if I do it right here, and we have C6, C7, this is spinal column going down like that. If I damage it right here at C5, I can still breathe on my own. Right. However, what can I not do? What comes off of C5, C6, C7, C8? Remember there's 8? This is brachial. What is brachium? Where is your brachium? This is like brachium, antebrachium. We talk about that in lab. So these from C5, 6, 7, and 8, these all go to the arm. So if you have damage right here, then you're a quadriplegic. You don't have movement of your arm, no sensory from your arm, and you don't have movement and sensory of the legs. So I'm trying to think, you think about layers of the spinal cord. Now, when you get down here to T1, C8, T1, what happens if you have damage at T1? I can still move my arms, so I have full use of my arms, but you have no legs. You're paralyzed, you know. Okay, so then you get your lumbar plexus and the sacral plexus, depending on where it is. Now, hopefully nobody's going to get paralyzed like that, but what does happen is, what if you're down to like C4, or not C4, lumbar 4, lumbar 5, you know, you're getting in the lumbar region. Depending on where you have a herniated disc, what's your symptoms? You know, what's the big nerve that goes down in the back of your leg? That's the sciatic. Okay, so it comes off certain areas. And again, it's a plexus, so it can be really bad, can be not as bad. You know, it depends on where the fibers are coming from. If it's the area in the front that's hurting, many times it's coming from the femoral nerve. And there are different layers of the spinal cord, which is, you try to figure out where the damaged area is. And if you do an X-ray, you can say, well, the space between the bones kind of thin, you know, and most people can do X-rays. Then if you do an MRI, you might see it bulging out, but it doesn't necessarily send you to surgery right away, because sometimes that bulge will go back in. Sometimes you have really bad pain, and then it gets better, and then it gets worse, and so you're trying to think of the spinal column and where the layers are. That makes sense? Okay, and I did the cervical, so I did the phrenic. I did that one, and I let the other ones go in lab. Where does the spinal cord end? L1, L1, okay. So the cord, the hard part ends here, the whole column is longer, so that's why you go into like between L4 and L5 to do a spinal tap. You go in there, and what is the nerves that are floating in the dural sac? What do those nerves do when you stick a needle in? It's like sticking a needle in spaghetti, they move out of the way. So you're not going to damage by going in there. If you go into here, you're going to damage the spinal cord, and again, it's irreparable. So you don't do any of that. Okay, so we know where it ends, where you're going to do a puncture. Talked about adaptation, you know, sensory adaptation. Where does that occur? Like in the olfactory. You get sensory adaptation for pressure. You sit in your chair, can you feel it? Only when you first sit, and then you forget about what does not adapt.
Taste.
Actually, I think taste does, doesn't it? If you eat something sweet, then what do you want to eat? Salt, and then you want to eat sweet. I think there's a little bit of adaptation in taste. That wasn't what I was thinking. I was thinking the general thing is pain should not adapt. How about heat and cold? Hot tub, cold tub, you know, you get in a hot shower, and then you start cranking it up higher and higher. Because you get used to it. You're adapting to heat, you adapt to cold, pressure, but you don't adapt to pain. You should not adapt to pain. When you adapt to pain, then you're losing a big sense. So pain doesn't usually show adaptation. Olfactory is real good. We've worked with that a lot, right? You know that. Okay. When you divide it down into here's your cerebral cortex. Okay, cerebral cortex, that's the outside. What color is the cortex? This is cerebrum, C-E-R-E-B-R. This is your upper part. This is the thinking part.
Gray. That's great.
Okay, the color is gray. Why is it gray? No myelinated axons, or very few, but it's cell bodies. And if you have cell bodies, most of the time, not all the time, if you have cell bodies and dendrites, these are not myelinated, and so that gives you the color. Most of the time, you're going to have synapses then. Not all the time. Where would you not have synapses? Remember this one here somewhere? You have a dorsal root ganglia. There's no synapses. Weird, okay? This just has cell bodies of these sensory nerves. But most places that are gray have cell bodies and dendrites, and there's usually synapses or connections. Okay, so here's the cortex. What do? You think in the cortex. These are higher centers. We talk about higher centers, thinking. In the cerebral cortex, what is the part where your intelligence and everything's located?
Prefrontal.
Okay, so it's in the frontal cortex. And where in the frontal cortex is called prefrontal cortex. It's in the front of the front. And don't get the prefrontal cortex mixed up with the premotor. What's a premotor do? It's voluntary motor that's taken over, like in sequencing, like playing an instrument, typing, playing the piano. Excuse me, pardon me. The premotor is in front of the regular motor. And so that's when you take over things that you do and you get used to doing, and you don't have to think about them anymore, but they're still motor.
The prefrontal is the emotions.
This is prefrontal would be your intelligence, your personality, conscious, your planning. The thing that kind of makes you is in the prefrontal.
So different than frontal, because frontal is thinking.
Frontal is the whole thing. The
Yeah.
prefrontal is like a seat of being you.
Okay.
Because the back part of the frontal lobe initiates motor activity. Remember, and right in front of that's called the motor cortex. That's the part where you take over things like typing, musical instrument playing, things that you can do without thinking, but they're still voluntary motor activity.
So which one initiates the movement, did you say?
The part that initiates would be the pre-central gyrus, and you don't have to kind of remember. It's a pre-central of which lobe, the parietal or the frontal? Okay, initiates motor activity.
Pre-central gyrus of the frontal.
Okay, all decent cars have a motor in the front, right? Mm-hmm. So not Volkswagen. Okay. Motors in the front. Motors in the front. So all the motors. So initiates motor activities comes out of the frontal lobe. It's actually the precentral gyrus of the frontal lobe. And if you're going to move your right foot, where do you initiate right foot? Okay, right foot is going to be initiating motor activities. It's going to be on the left side. Remember, they're crossed. So the frontal, the key word on the frontal is initiates motor activity. Prefrontal has more to do with intelligence, planning, thinking, ideas, and that's really up front. This is where you probably do short-term memory. This is where you decide if you drive too fast and you hit a tree, you're going to die. Okay, that's unconscious. Doesn't really develop real well until you're in your early 20s. Okay, so give your kids a break. Okay, so this is prefrontal. And then we also have another, it's called premotor. Don't get them mixed up. Premotor just means things like typing, automatic motor activity. Where is Broca's area? The Broca's area is still going to be in the frontal lobe. Broca is speech, right? Okay, speech. And what side is it in most people? Because it seems to be localized. It's on the left side in most people. Broca's area is for motor speech. I think they pull, everything's kind of pulled to one side. So most people it's on the left side. Which is a common area, so if you have a blood vessel come up with a little clot there, hits that, all of a sudden you can't talk, right? Because Broca's area on the left side will be damaged and then you lose speech ability.
want to make sure premotor versus precentral. And so premotor just
This is where you take over. This is like you take over.
from the precentral.
Yeah.
It's learned activity.
It's okay. That would be a better
Muscle
one.
memory.
Okay, muscle memory. That's a good one. Muscle memory. And you. What was the other thing you said? It takes over. No. Muscle memory learned.
Yeah.
You know, it's learned motor activity.
That's
So if you damage that, area, you can no longer, if you play the piano beautifully, you have a stroke in there, you can't play the piano. However, you could go do individual fingers because you could initiate it, but you wouldn't have this thing that has taken over and learned it.
So it would be like going back to square one.
Square
you could,
one.
You could still type, but you would have to go back to like
This
you
is
would never
square
learn
one.
how to.
This is square one. This is where we move some of the stuff so we don't have to think about it. And the brain's a whole lot more complicated than I'm trying to put, to show. Because there's things with walking and
Could you ever relearn?
you
the
could
stuff
relearn.
to put it back.
Yeah. And see, that's what they do, is you have a stroke and they put you into some
therapy.
kind of therapy. And do you grow new neurons in most of your brain? No. What do? You grow more
Reroute.
axons, you want
Gotcha.
more connections. If you have a damage to this, maybe, depending on how young you are, if you're real young, you can just shift it to the other side of the brain. Like a young kid having a problem with that, they can actually do a lot more than an older person. They just shift it to the other side. So yeah, and that's what you're trying to do, is you're trying to make new pathways. And when you're learning, you're not adding new neurons. What are you doing? You're making the connections stronger. You're having maybe more acetylcholine go across, or dopamine. You're making physically a stronger connection. Maybe you're putting glue between them. And you have to just keep doing over and over to try to make the pathways stronger. And that's kind of what your memory is. Okay, so cortex, central cell bodies, dendrites, synapses, this is where you're thinking. You just do general thinking. What if you don't have the cortex? What if you don't have the cerebral? Okay, anencephaly, N-C-P-H-A-L. I don't know how to spell it. Anencephalus.
Close enough.
Somewhere there's a Y in there. Okay, so what does it mean? You don't have, and this E-N-C-E-P-H means brain. This means the thinking part. Anencephaly is a neural tube defect, right? The neural tube, when does it form? It forms within the first couple of weeks. Really, really early, actually first week. And so what if you lack, what's the vitamin that if you lack it goes up?
Folic acid.
Folic acid, okay. So now they're saying when you're doing folic acid, you should be taking it 2 months before you're pregnant. But if you do have a lack of folic acid, you have more neural tube defects. Anencephaly is the top doesn't form. What if the back doesn't form?
Spina bifida.
Yeah, so these are related. This is spina bifida. Okay, and this is the spinal cord doesn't completely close over, the vertebrae don't completely, and it can be minor, it can be horrible. It can be minor or major. Okay, so these are both neural tube defects. Lack of folic acid increases their incidence. So know where they are. What would be, and this is considered a high center, right? We call it high because we're thinking. Okay, so this is the higher centers, thinking. Where's the lower centers? Okay, let's put the lower centers down here. This would be like the brain stem. What is in the brain stem? We have one of them primarily is the medulla part, and we're not spending a whole lot of time in individual, but these are more this is called lower. These are the automatic stuff. Why do you breathe regularly? I'm not thinking about breathing unless I'm talking, right? Mm-hmm. But if I'm not talking, I breathe on a regular basis. Where is that breathing coming from? It's coming from the brainstem. Sends out. So this is your automatic stuff that keeps you alive is coming from down here. Like it sends out breathing. So these are things that keep you alive. There's vomiting centers. There's centers for balance. There's a lot of stuff in the brainstem, but we consider it the lower because you're not thinking. If you have anencephaly, you may develop this, so some babies will actually be born and live for a very short period of time. Because this is intact, but they don't have the top part. Okay, so that's why it's called lower, upper, but it keeps you alive. Now, so we have in between here, so this was the cortex, and then we have this thing that's right here, which is called the hypothalamus. My favorite. Okay. So what is the hypothalamus? What would be a key word for hypothalamus? Visceral. Visceral. These are not conscious stuff. The visceral. The hypothalamus controls the pituitary. We'll talk a lot about hormones next semester. Hypothalamus controls sends out information for your parasympathetic nervous system and your sympathetic nervous system. How does it make the heart speed up? Hypothalamus sends those nerves to the brainstem, and in the brainstem there's going to be a nucleus that has to do with your heart rate. And then that heart rate thing, there will be a nerve come out of there that then will go to the heart, and if it's a sympathetic nerve, it will go to your SA node and it will speed up the heart. So the hypothalamus is the seat of your autonomic nervous system as well. It does body temperature, it does osmotic pressure of the blood, it does a whole lot of stuff, and it controls most of your hormones. It controls the pituitary gland, and then the pituitary gland releases a lot of hormones, but the hypothalamus controls your pituitary. And you start out probably with endocrine next semester. Okay, so how does the hypothalamus control your heart rate? Hypothalamus sends information to the brainstem, sympathetic or parasympathetic, and from there it sends it to your heart, sends it to your blood pressure sends it to your vessels for blood pressure. So your autonomics. Now, what's the difference between autonomics and somatics? When you say autonomic, you're talking.
Somatic is when you do it on your own.
You're not doing it on your own because you're not telling it what to do. It's doing it on its own. Autonomic is automatic, which means you can't control it. So if the hypothalamus sends out here, then it comes out here as a sympathetic or parasympathetic. Going back to, can you control the hypothalamus stuff? Okay, what happens if I'm thinking scary thoughts? Okay, scary. I'm thinking, okay, what will happen to my heart rate? It will increase. How? If you're thinking stuff, the thinking stuff will feed down to the hypothalamus. The hypothalamus, if you're scared, which of these is sympathetic? Sympathetic, okay? And then the sympathetic will go to the rate center in the brainstem, and from there it will go to the heart, speed your heart up. So see, the autonomic is going to be under the influence of your thinking, but it can do everything automatically, but you can influence. So the way when you get scared, the reason your heart rate goes up, which is autonomic, is you think and it feeds into the hypothalamus responds. And so you can see how it would speed up your heart. But what if you decide you want to slow your heart rate down or lower your blood pressure or increase flow in your fingers? Some people can actually do that. Okay, how do you do that? You think calm thoughts, right? What happens if you're thinking calm thoughts? And you try to relax all these things. Well, as you feed that information, it takes some time, and you have to be able to monitor it, like it's called biofeedback. You think things calm, sends it into here, you try to activate the parasympathetic just because you're trying to slow your heart rate down, and it goes here, and then it will slow the heart rate down. It's like a relaxation. So you can influence through the hypothalamus, but the hypothalamus is the seat. But your thinking does influence it. Your thinking does influence it. So this would be considered the high center. Hypothalamus is all your visceral activities are coming out of this, and one of the big things coming out of it would be the parasympathetic and the sympathetic nervous system. So what is the parasympathetic nervous system? What is the neurotransmitter? What is it? If you get the sympathetic and the parasympathetic mixed up, you're really messed up. A lot of questions. Okay, so what's the name for parasympathetic? You're screwed. Okay, what's it? Peace. Okay. And just, you do it the easy way. Okay, parasympathetic is peace. Peace, we're talking resting when you're sitting there, and also positive for digestion of your food, which means your salivary glands are making nice, good saliva. Okay, what's the transmitter? Let's switch to the other one. What's sympathetic? Okay, that's stress. Okay, what is that called? That's called fight. Your blood goes to your muscles, or you run like crazy, fight or flight. What is the transmitter here? Think about this. Okay, you know when you get frightened, we talk about our adrenaline flows. Remember adrenaline? Common name. Adrenaline flows when you're frightened, right? Or you're excited, whatever. So what is adrenaline? Adrenaline is the same as norepinephrine or epinephrine. Actually, adrenaline is epinephrine, norepinephrine is noradrenaline, okay? So norepinephrine and epinephrine are the correct terms for using that thing. And so stress, if you have norepinephrine and epinephrine is a hormone that released, it's logical that the transmitter is going to be one of these. And the one that it is usually norepinephrine. So sympathetic, stress, and you know adrenaline, right? You go with whatever you know. The way your memory works, you layer on stuff you already know. Your adrenaline rushes, you talk about an adrenaline rush. Adrenaline would be norepinephrine and epinephrine. These are hormones, so you know that it's connected to that whole system. So by elimination, what is the parasympathetic transmitter? And it's the one that goes to all muscles. It's also called acetylcholine. It goes to the muscles, and it's all your parasympathetic. So how does the heart know what to do? If it's a sympathetic, it releases norepinephrine on the heart speeds up. If this one is a parasympathetic, it releases acetylcholine, slows your heart down. And what's happening most of the time, coming out of the vagus nerve, vagus is a big parasympathetic nerve. It's going to the heart, and it's telling the heart to beat about 75 beats per minute. Slows the heart down. If you cut all the nerves to the heart will go up to 100 beats per minute. So what does that tell you? Most of the time the heart is going slow down, slow down. So when you're sitting there right now, what system are you under?
Stress.
Yeah, stress.
That's when you go to the test tomorrow. Okay. So right now, you should be under parasympathetic. You cannot stay under sympathetic a long time because it hurts your body. It inhibits your immune system. You're under stress, it inhibits your immune system. Your white cells go down in activation. You catch colds, you know, all this kind of stuff. So normally, the parasympathetic to the heart keeps it going slower. If you cut the nerve to that, the heart automatically will go up to 100 beats per minute, which is too fast. If you get frightened and norepinephrine is released here, it will go up too. But just backing off the parasympathetic will raise it up. So what is the nerve that goes to the heart that's a cranial nerve? Vagus. Vagus. Visceral nerve. Vagus. Vagus is primarily a parasympathetic nerve. So the vagus is, what's the number?
10.
Got to know the number. That's X, 10. So the vagus is a parasympathetic nerve. Most of the outflow from the vagus almost is parasympathetic. It's the major parasympathetic. It goes to your visceral. Sensory comes in through the vagus. It's not necessarily part of the autonomics, but it's a visceral nerve. So vagus, visceral, vagabond, all things that help you remember vagus. And so the nerve going to the heart is the vagus nerve. That's part of it. You cut the vagus right here, your heart will speed up, because normally it keeps it slower. Okay, so the hypothalamus is the seat of the autonomic nervous system. Hypothalamus monitors your temperature. When your temperature goes up to try to fight off disease and you take Tylenol or Advil or something like that, it resets the hypothalamus and your temperature goes back down. It's a lot of visceral. So the key word here would be visceral. And as you study next semester, it'll be good because you'll be going into all the parts of the body that have to do. And you need to know autonomics because you can't control your digestive tract. You can't control all these things that are happening. Most of them are going to be autonomic. Digestion, respiration. See, one person just started yawning. Now everybody's get going yet. Okay, so we got this coming down. Okay, here to hypothalamus, down, out. So we got the downflow. We talked about the breathing nerve. What's the breathing nerve called? Phrenic nerve. You're frantic. So let's go back and say, okay, we've kind of gone downward. Let's go back and do upward. Okay, we do upward. We'll forget about the parasympathetic right now. But again, if you mess up the basic thing, you mess a lot of questions. Which one do you like to look at first? Always go to the sympathetic. Because if someone's running, what are they doing? You can see them, all the effects, right? And what about the sympathetic? It activates a whole bunch of things at once. your pupils dilate, your heart beats faster, you increase your glucose, all the stuff that's on that handout. Everybody should have that handout. Know the handout. All that stuff. So it's easy to see sympathetic, and then whatever's opposite is going to be parasympathetic. So I always go with the sympathetic first, because you can see that, even though the book has it backwards. Okay, so this would be coming down. Now we want to go, okay, we're going to do something like pain. I'm going to step on attack. Okay, you have a nerve that goes into the spinal cord. Here's the spinal cord, and it's going to go in the dorsal root, right? Dorsal root. Go into the spinal cord, synapse in the spinal cord, and then what is the tract called that goes upward? And it's going to end in the sensory. It's going to end in the thalamus. Does the thalamus have anything directly to do with the hypothalamus? This is here, and the hypothalamus lives below it. That's it. It's a naming thing. They're not technically that related. Okay, so pain happens, goes into the spinal cord fires. What do you call this going up to the thalamus? This is called a tract. What would you name the tract that starts in the spinal cord and ends in the thalamus? Spinothalamic, you're right. Okay, so spinothalamic, and it's in the central nervous system, that's why it's called a tract. And a tract means it's only one way, right? So if I give you this tract and ask you if it's ascending or descending, you can do it. Ascending. Okay, so this is an ascending. You step on attack, you have one neuron.
I'm sorry, the way it's named, is that where it starts?
It starts, ends.
Yeah, okay.
So it tells you, so when you get the name, now there's some other ones called funiculus cunatus, and we're just not doing those. So some of them don't tell you, but you either have an ascending tract or you have descending tract. And they actually go in certain parts of the spinal column. Because it starts in the spinal cord and it ends in the thalamus. And so that's what I'm asking you to learn, is that if you see the spinal thalamic, you know it starts in the spinal cord, and it ends in the thalamus. And what does the thalamus do? Remember, that's the sensory relay station for all sensation. All sensory goes into here, and then it synapses, which remember, it synapses and has another neurons, and they're going up to the cortex. So if we could do a synapse here, if I could actually draw the stupid thing. Here's a synapse going up to here. What color is the thalamus?
Gray.
This part is gray. What color is the spinal thalamic tract? White, because these are myelinated fibers going somewhere. Okay, and so a tract is in the central nervous system. It's one way. It's the fibers. And these fibers I'm talking about are the axons, the myelinated axons primarily. When you get into the thalamus, it's synapses. And if this is like pain, it goes into the thalamus. Synapses, where does it end up in the cortex if it's pain? What lobe? Parietal.
Yeah.
And what does it do when it gets to the parietal lobe? What part of the parietal? Is it the primary or the association? Where does it go first? It goes here. So if we scratch that out, it goes to the primary. And what do you do in the primary? You can say it's a pinching kind of pain, but you don't know what it is. Then it goes to association, and that's where you can say, oh, you know, a lizard has bit my finger. This is what it feels like. You know, you could be more specific. Okay, the type of, you know, whatever damage it is. So the primary is where you go first, right? And what is in the association areas? Memory. And there's a lot more of association than there is primary. What is the primary for the vision? Where does that go? Occipital. And what do you see? Colors and patterns, and that's it. How do you know if you see a face or you see a building? Memory. And if you don't feed that memory into your children when they're growing up, if they don't get to see a fire engine, how can they know what a fire engine is when they read it in a book? They need to see. They need to add memories. You're adding all these memories. So the difference between primary and association, yeah.
There was, I know in psychology, they talked about a woman that couldn't memorize faces. Like every, you know, like even her own husband, she
couldn't remember her own face.
She couldn't like recognize them. So every time she saw someone, like she was seeing them for the first time. So that
and that was because she couldn't. It was a problem in her association areas. Yeah.
But she could recognize voices, right?
think, I don't remember, I suppose she couldn't recognize.
And she may have had like
She couldn't
a
recognize her own
stroke in
face.
the association
Yeah,
area.
even her own face,
Wow.
And see, people sometimes with association, there's weird things that happens and they just ignore one side of their body. They can't see it. They can't feel it. They don't know it's, you can sit there and go, that's your hand, and they go, no, it isn't. And so there's a lot of weird things. Like they'll take care of the one side of the body, but they won't take care of the other side. They won't wash, they won't, And so there's a lot of weird things that happen. Simple. Primary is where it goes first. What would be for, where does it, when you hear something, what do you hear? In the primary lobe, you hear a certain pitch, which is a frequency of sound. Volume, loudness, and it tells you where the sound is coming from. If you hear, if it's from there, you hear this ear first and this ear. So those are the only three things that you get. How do you know who's talking, or what do you know what it's saying? You have to go to association, because that's where the memories are. That's where your connections are. And a lot of times in the brain, it pulls from all these different areas. Your parietal and your occipital and your temporal kind of work together. But we're separated. We're keeping them separate. It's easier that way. The sidedness, we said Broca's area was where? They do Broca's?
yeah, that's right there.
Yeah, we said Broca's is on the left side. So the body has taken over and saying most people are just going to concentrate motor for speech. The muscles that do speech on the left side. And other things would be you do more stuff on the right side, spatial skills. And that one thing that's interesting in the boy-girl brain, it's an older article, but it's from the older book, and it talks about, during development, about 3 months into development, the baby boys have a wash of testosterone, and as it goes through the brain, it cuts a lot of the corpus callosum fibers. So boys don't do this back and forth as much. They do more straight line thinking. And my idea of straight line thinking is you go to Lowe's and you can only buy the screws that you want. You can't go look at the bodies, because that's different. Women do the, let's go look at everything. Usually men go, okay, we're going to Lowe's, we're only going to be this, and there's a straight line thinking, which helps with cutting and that kind of stuff. Women tend to do this multitasking, and they really shift from the right side to left, which makes them better verbally. You look at a 5-year-old in kindergarten, and the girls talk all the time, the guys make noises. They don't do it.
I've actually heard that that's one of the reasons that women are able to have better memory than men, is because their emotional parts of their brain and their thinking parts of their brain have better flow between the two of them. So with a man, a memory of, I went to Walmart and bought a gallon of milk, is just that. But with a woman, it was, well, I was having a bad day, and I went to Walmart, and I got a gallon of milk, and I saw the sale on aisle 2 that had $2.33 for Swiss rolls or whatever. But it's the emotions and the thought tied together which creates a stronger bond.
Again, what connects your right side of the brain to your left side? What's that structure?
Corpus callosum.
Corpus callosum, what color is it?
White.
White, because that's axons. And they say that the testosterone early on cuts some of those fibers between the sides. So it gives them better advantage in certain tasks, and women have better advantages in other tasks. And that's on that thing. I
So
thought
do
that was
some guys, do theirs do?
Some guys are just better verbally, but in general, the average woman has a better verbal back and forth.
So, but there
Verbal.
could be some
Not-
guys
but that's
that
average, huh?
But it could be that some guys have that too.
Yeah.
Because, some guys are like that too, they're real good at everything and talk a lot, like a woman.
Yeah, but that, I don't know for sure.
I know they are. I don't mean the feminine, I mean, but they.
And we're doing the average. The average men speak this many words, the average females speak,
So leave us alone. We're brain damaged from birth.
And that's what we're doing, like the average, some people require, but women tend to have being able to do multitasking usually easier because of this back and forth, which probably helps the kids survive. Okay, so going up, everything goes up through the what? Thalamus, synapses and thalamus, and then it goes to where it's supposed to go. If it's visual, it goes to occipital. If it's auditory, it goes to temporal. So you need to make sure you can do the different lobes, what they do, where you have motor control. I was trying to think of okay. So we have cortex, going down cortex, we have hypothalamus, we have autonomics. Going up, we're going to have tracts, synapse and thalamus go into the different lobes. What does the cerebellum do then?
Smooths things out.
This one comes the initiate activity, and then the cerebellum, this is the longer word, right? C-R-E-B-E. This is the longer word, so it's a little brain. It's a littler one. They call it little brain. And this also receives information coming up from your body, tells you where you are. And from your vestibular apparatus, tells you where you are. And so you decide, I'm going to lift my left foot and move. Well, all that information goes into the cerebellum, and the cerebellum goes, okay, we better make everything else work so that we don't fall on our face. And so we say that the cerebellum is coordination. Okay, it's coordinating the muscle activity. It's coordinating the muscle activity. This is on subconscious. You're not doing that consciously. That would be subconscious. So make sure you can do the individual, when you look at what happens, make sure if you were to walk through and say, this does this. I had one sheet, but I just listened.
Is there going to be any vocabulary on there?
Sensory, but,
Well, almost everything is vocabulary anyway.
well, if it's sensory, senses that everything's going, and then the cerebellum figures it out, like, ooh,
Let me, want to do cranial nerves? You want to do cranial nerves?
I'm sure
How are
it
you
would
on
be like where it passes through, because it's gonna, little brain's gonna get information, just telling you to go that way.
See, at the
Would it, I wonder if that would be like homeostatic, that would help you with homeostatic balance or whatever for equilibrium. But that would keep the time.
See you guys.
Well, see,
Okay, so, and I didn't talk very much about the basal nuclei. I did go back on the basal nuclei. The correct name is basal nuclei, and what it does is it inhibits most unwanted movement. It's more of a modifier. The cerebral cortex is initiator, cerebellum is a coordinator, and the basal nuclei inhibits unwanted muscle activity. And on the quiz, I called it the basal ganglia. Why is that wrong? Because ganglia means outside, and the basal nuclei is inside of the cortex, is part of the central nervous system. So when I went back and regraded the test, if you got basal ganglia wrong, I gave you credit for it. If you got it right, I didn't do anything. But I did go back and change a few of the grades. Somebody else, I had to correct their test as well, because I made a mistake on it. So those I already corrected. So we want to do the cranial nerves.
sure.
Again. We did the things. I'm trying to think. If you get the sympathetic, and again, what was the difference between parasympathetic and sympathetic? If you want to run, you want everything to work together, right? So when the sympathetic kicks in, norepinephrine's released as a transmitter, and then it goes to your adrenal medulla. What does adrenal medulla release? Norepinephrine and epinephrine, right? So you potentiate it, everybody's ready to run. If you reduce the parasympathetic, what do you do? If this is the parasympathetic, and this nerve is called a preganglionic. Why is it called preganglionic? Okay, so then it gets to the ganglia, and then this is the postganglionic. And this is the neuron, has the cell body inside, spinal cord, synapses. This is the ganglia. In most cases, the parasympathetic ganglia is right on the organ. Why? It's right on the heart. It's right on the bladder. Because if the parasympathetic fires, do you want to slow down the heart, and you want to contract the urinary bladder, and you want to constrict your eye at the same time? Let's be more specific. If you have a preganglionic synapse, this can be more specific. Parasympathetic can say, slow down the heart, leave the bladder alone. It can go to the pupil, cause it to, what, constrict or dilate? Parasympathetic, resting and digestion. Constrict. Bright light will constrict it because it uses the parasympathetic, or if you're relaxing, it should constrict. So if you have someone and they have this it's really, really bright light and their pupils are dilating, something is wrong, right? Either they're frightened, you look at your cats, scare your cat and watch the pupils dilate. Sympathetic, right?
Or they're on drugs.
Or they're on drugs, yeah, well, that would be that would be the common thing. So the preganglionic is real long in the parasympathetic, and why is it, if this was a sympathetic, what happens